Great. Welcome back from lunch or from an extended break. We are ready to get right back into things today. So we are super thankful to have Dr. Paul Sachs here for our next talk. He's a professor of medicine at Harvard Medical School, and he's the Bruce A. Beal and Robert L. Beal Distinguished Chair in Infectious Diseases. He's a clinical director of the Division of ID at Brigham and Women's Hospital and editor-in-chief of Clinical Infectious Diseases. And he is here to discuss the care of the hospitalized patient with HIV. So I will turn it over to you, Dr. Sachs. Thank you.
Well, thank you, and thank all the course directors for inviting me to give this talk. It is let me just tell you, it is a thrill to be able to talk about this viral infection instead of the one I've been talking about, which has been COVID-19. But this one's still very much with us, this HIV topic. And so what I would like to focus on in the course of our discussion is what it means to you as a hospitalist to care for people with HIV who get hospitalized. I'm going to start out with a refresher on HIV testing. I'll then move on to the key concepts for managing people with HIV when they're admitted to the hospital. I will cover antiretroviral therapy, at least what you need to know about it. And then whenever possible, I will be using the case-based format. And periodically, I'll have some ARS questions for you to weigh in on. So here's the first case. This is a 65-year-old woman who was admitted with confusion. And the story is as follows. She got lost while driving home, and the police brought her to the hospital. And the family, when they arrived, they say that she's been having a memory decline for the past year. Her exam is normal except for her neuro exam, and she has moderate memory impairment. And as part of her workup, an HIV test is done, and it's sort of part of a broad screen for early onset neurocognitive disorder. She does not have any risk factors that she reports, and she was born and raised in the Boston area. And her imaging is notable for mild generalized atrophy beyond what you would normally see for a woman her age. So her HIV test is sent, and the results are as follows. She has an HIV antigen antibody assay that returns reactive. Her HIV differentiation assay is negative, and the final interpretation of this test is that it's indeterminate, and you can vote any time. What is the most likely outcome of her HIV workup? A would be HIV-associated neurocognitive disease, or HAND, which used to be called AIDS dementia. B is acute primary HIV infection, and she's in the window period and in the process of seroconverting. C would be that she has encephalopathy due to HIV-2, which is triggering this indeterminate result. And then the last is that she has a false positive HIV-1/2 antigen antibody test. So go ahead and vote what you think the most likely answer is. And eventually I'll get to see the results and I'll communicate them to you. I know it takes a little while for these to appear. And I realize that that's just part of the system and not a reflection of our own HIV or other related dementing process. But as a teacher in my own course that uses the system, I realize it does take a little while. So I'll give you some time to make that assessment. So go ahead and vote. Okay. And let me see the results now. And I'm having a little... Okay. Okay, so the majority of you actually voted for the correct thing, which is the answer, which is D, and well done. And I did give you the answers on my slides, but that's okay. You're welcome to try to challenge yourself. Going to mention that we do, the first test we do is this combination antigen antibody assay. So it detects not just antibody, but also a circulating antigen that's present after recently acquired HIV, and that recently acquired HIV is usually in the order of 70% sensitive during recently acquired HIV, whereas the antibody test is often negative. So once that screening test is done, it's now sent for a confirmatory assay, which is often called a differentiation test, which distinguishes HIV-1 from HIV-2. And the whole goal of moving in this direction and removing the Western blot was that it actually shortened the window period because that antigen assay can be positive before the antibody develops. And the other thing is that the differentiation assay can be automated, and it's much less expensive and faster than the Western blot. So if we take a look at our algorithm, we can see that this patient has a positive HIV-1, HIV-2 differentiation immunoassay. And then she had a negative HIV-1/2 differentiation assay. So she then had a viral load test, which came back at less than 20. That's the lower limit of our assay. And so our interpretation, which is correct, is that this is a false positive HIV screening test. So if we go back to our flow chart here, she had a reactive differentiation assay, a reactive screen, and then she had a differentiation assay, which was negative, and then she had an HIV RNA done, which was negative. So that is an indeterminate result with a final conclusion of a false positive test based on the fact that her viral load was negative. So why do we have so many of these indeterminate tests? Well, it has to do with specificity and sensitivity and Bayes' theorem and pretest probability and all those things we learned about when we went to medical school or PA school. And we basically learned that if your pretest probability is low, then you're going to have more false positive tests. And even though the test is very good, it's 99.4% specific, which means that as many as 4 in 1,000 test results may be false positives. And this is actually a higher rate than we see in people with acute HIV who have this same test result. So that's the kind of confusing piece of this, which is why if you're testing someone low risk, never ever tell them they're HIV positive with just a reactive screening test, because it's a high likelihood it'll turn out not to be confirmed. Now, what about if you get a positive result on both tests? Well, then you really do have a highly predictive result. This is so good that the false positive rate of the combined assay is about 1 in 200,000 or lower. I have seen a few cases in the course of my career. They are most common in people with autoimmune diseases, and sometimes happen in people who are pregnant, but very, very rarely. So don't ever discount that, no matter how low risk that person is. But the take-home message here is if you test a person who is low risk and the result is indeterminate, check a viral load. The reactive screen is most likely a false positive. So that's our first case. Now let's move on to a second case. So this is a 45-year-old man who was seen urgently in the emergency room with fever, sore throat, rash, and diarrhea for 7 to 10 days. And he's sexually active with men within the previous month, but he does not always use condom. And he was on pre-exposure prophylaxis, but he stopped it 2 years ago. And he has a fever of 101.5, cervical adenopathy, rash, mild neck stiffness. His white count's low, and you can see he has 8% atypical lymphocytes. Heterophile test is sent, and that comes back quickly as positive, and HIV testing is also sent. And the rash looks like this. It's all over his body. This patient allowed this rash to be shown for educational purposes, as long as it was de-identified. And now we take a look at the results of his testing. And his testing has the same result as the previous test. Previous case, his antigen antibody assay is reactive, his differentiation assay is negative, and the final interpretation is the same as the previous test case, which is that it's indeterminate. So here, what's the explanation? A false positive screen because he has mononucleosis. B, a false negative HIV differentiation assay due to the fact that he's in the window period. C, he has a laboratory error. Or D, it's Lyme disease because this is New England. And I have to credit my colleague, Daniel Solomon, with that joke. And because I have shamelessly stolen it. But tick-related infections are very common in these parts. So anybody who shows up with a fever in the middle of the summer has has Lyme disease or a tick-related infection until proven otherwise, but that's not the answer here. So let's take a look at the answers. See if I can get them shown a little bigger. And it is the most, I'm having trouble seeing them. The most common answer was false negative HIV due to a window period, and that is correct. So I'm going to not show that any longer. And whoops, so go back to my screen. The answer is false negative differentiation assay due to window period. So what happened with this case? The viral load turned out to be greater than 10 million copies, 10 per ml. That's the highest level of our HIV viral load test. Remember, the lowest level was 20. Our highest is 10 million. CD4 cell count was only 200. The diagnosis that was made was that he had acute HIV with multisystem disease. He was started on HIV therapy the day his HIV RNA viral load was returned and discharged on hospital day number 4. So here, let's go to our algorithm again. He had a positive screening test. The antigen antibody is positive. He had a negative differentiation assay, just like the first case, and then a positive viral load. And the take-home message here is if you're considering HIV infection that's recently acquired, acute HIV infection, you should also order an HIV viral load right off the bat, because that way you avoid some of the confusion and make the diagnosis more quickly. So why is this the case? Well, this is a very nice figure from David Spack at the University of Washington. If you look along the horizontal axis, days following HIV acquisition, the first test to turn positive is the HIV RNA or viral load. And there it is, positive about 7 to 14 days after HIV acquisition. At this point, the next test to turn positive, the HIV antigen, is still negative, but it will turn positive before the antibody test. The antibody test is the last test to turn positive. And so this is the window period before the antibody test is positive, where you have first detection of HIV viral load, and second detection of HIV antigen, and third, finally, detection of HIV antibody. So this means that the test that we're using to confirm a reactive screen is the HIV antibody test, and that's why there's delayed diagnosis of acute HIV infection unless you send an HIV viral load. So we have a really good way of testing for HIV. It's a good, really good test, but it's not perfect. So I've already mentioned in case number 1 is that the high proportion of reactive screens in low-risk patients are false positives. And then the second problem is that the confirmatory test, which is the antibody-based differentiation assay, may miss acute HIV infection because people haven't seroconverted yet. So there is a solution to this, and that's to swap the confirmatory tests and have the confirmatory test be a viral load rather than the differentiation assay. But there are a few reasons why this has not taken place more broadly. First is that viral load quantitatively has been validated in plasma, not serum, and most people draw a serum sample for HIV testing. Second is that there's only a limited number of viral load tests that are FDA approved for diagnosis, and if you do a non-FDA approved test for diagnosis, there may be issues with reimbursement. And then finally, and this is something we certainly learned during COVID, is that the molecular tests like viral load testing are way more expensive than antibody tests. And so you don't want to sort of saddle the healthcare system with this more expensive test, even though that's an artifact of kind of coding and billing. It is the case. So, the healthcare system and our patients might get billed for these expensive tests if they're ordered quite broadly. But I am pretty confident that eventually this is where we'd be heading, which is using the HIV RNA as the second confirmatory test rather than the differentiation assay. So let's talk about the case clinically. This is someone who had a lot of different symptoms. You can see that skin rash and diarrhea, which he both had, are present. And this is kind of one way to distinguish it from acute mononucleosis, which it very closely mimics. Skin rash is not that common in acute mono. Diarrhea is certainly not that common in acute mono. But other than that, it looks a lot like it. This is HIV is one of the causes of mononucleosis syndrome. I want to mention also that some people have headache, and this patient, in this case, had a stiff neck. It's not uncommon for HIV to kind of cause a brief lymphocytic meningitis as it sort of circulates. And so if you did a CSF exam on everyone with acute HIV, they often end up with a pleocytosis and then culture negative. And this is the best of the series on acute HIV, and it shows how broad the clinical symptoms are. GI symptoms are very common. Most patients in this series did not have the diagnosis made at the initial encounter, even though many of them had obvious risk factors for HIV acquisition. And I'm going to emphasize this for your sake, because you are a group of hospital-based physicians and clinicians, that 17% of the people were sick enough to warrant hospitalization. So if you have someone who has an unexplained febrile illness, multisystem illness, and even has the slightest risk, I would go ahead and test them for HIV. Notice the diagnoses that people had made. Some had the diagnosis correctly made initially. Others, mononucleosis, especially that reactive heterophile. Remember that this is one of several triggers of reactive heterophiles. That's a non-specific test. A bunch of other diagnoses listed here. And look, endocarditis, diverticulitis, appendicitis, you name it. This is not an easy diagnosis to make unless you think of it. So I'm just asking you all to think of it. So we're gotten much better at testing people for HIV. This is the 2006 recommendations that we test everybody. I think even more important than testing everybody is the annual or more frequent testing for people who are at high risk. And the people at high risk are listed here. Men who have sex with men, that's MSM, are the largest category of people at risk for HIV in this country, but there are several others listed here. And we also test pregnant women, not because they're at high risk, but because diagnosis of HIV during pregnancy means that you can then give the mom antiretroviral therapy to prevent transmission to the newborn. And missing one of those cases is a disaster. And so we are gotten much better at this. So looking at our epidemiology now, depending on where you practice, you may see a lot of this in your hospital and may not see much at all. We have about now it's about 1.2 million people with HIV. The most highly prevalent areas are in the Southeast and then urban areas as well. Southeast is actually a pretty broad high incidence areas, including both rural and urban areas. We've done much better in this category here. 1 in 7 people who have HIV are unaware. That's an estimate, obviously, but it used to be as high as 1 in 3. But the removal of the informed consent requirement for HIV testing and the sort of destigmatizing it by just testing everybody has helped test people more before they get sick with the diagnosis. So the other thing to realize is not equal between sexes. Men account for more than 3/4 of the cases, as you can see here. So the last estimate, 79% men, 18% women. This has been sort of stable for the last, I'd say the last 15 to 20 years. This is not the case in areas where HIV is broadly endemic, and that includes sub-Saharan Africa in particular. And then in this country, the primary risk factor reported in 2/3 to 70% of people is male-to-male sexual contact. The second most common risk factor is heterosexual contact, and these are predominantly women. So women, it's been very hard to risk stratify the women with HIV in this country because frequently they don't consider themselves at risk. And second, because they may have had a limited number of sexual partners, but their partner who has given them HIV actually has risk factors. And so it's very, very difficult that they're not aware of. So it's very, very difficult, which is one reason why pre-exposure prophylaxis is so difficult to roll out in women in this country. It's much easier to offer pre-exposure prophylaxis for HIV prevention in men in the United States because they fall into a category of being at risk or not being at risk. This is a major challenge for us. So one thing I want to stress is that the hospital is a place where the issues of stigma related to HIV are really quite common. So these are just some reminders, and I need to be reminded of this myself. So allow me to share this slide with you. We've all made this mistake of disclosing HIV status to family or friends without explicit permission. And I remember one case where a man had been admitted with cryptococcal meningitis, and he talked to me quite extensively about how close he was to his family. And then on hospital day 3 or 4, his family was visiting him. And I just assumed, based on how close he was, that he had disclosed his really very serious condition to them, but he hadn't. And I made the mistake of bringing it up, which was, once you make that mistake, you often, it's a real learning experience, and you learn not to do it again. And some words you can use: is it okay if I discuss all your medical conditions in front of everyone, or would you prefer rather talk in private? One thing that's very helpful is if the patient mentions HIV during the history, then that certainly gives you a license to do so. A few substitute terms I've listed here: treatment for antiretroviral therapy. Questions about how you got HIV are very poorly received by people with HIV. Often they feel not just the stigma, but they feel like people are blaming them, or they feel still guilty about having acquired HIV. This is especially the case for people who've recently acquired it, because obviously we know how to prevent HIV transmission, but that doesn't mean that we know how to prevent STIs, sexually transmitted infections in general, but we don't actually. Human beings and their behaviors don't always follow these logics. And then one thing that is particularly problematic, and sort of interested in wondering, for all of you in the diverse areas that you practice, do you still take care of patients in shared hospital rooms? I do. Part of our hospital is single rooms, and part of our hospital is still double rooms. Very difficult to have these discussions, especially in someone who newly diagnosed or someone who's struggling with an opportunistic infection. And this is a good review from the New England Journal of Medicine of this issue in 2018. We were hopeful that once there was effective treatment for HIV, that we would no longer see the stigma, but in fact we still do. Okay, next case. This 64-year-old man with extensive smoking history, admitted with fevers, chills, and cough. His symptoms started about a week ago with an upper respiratory tract infection. In the past 2 days, he's much worse. He was diagnosed with HIV 20 years ago. He's now on antiretroviral therapy with a single pill he takes once daily. He can't remember the name of it. And his temperature is 101.5. He has bilateral rhonchi. And extensive wheezing. And then look at his chest X-ray, his multifocal airspace disease, right greater than left, consistent with pneumonia. I'm going to ask a question now. I saw that the formatting of our responses was kind of wacky last time, so maybe we'll just have someone tell me what the most common answers were. So if you could know only one thing about his HIV treatment history in managing him today, what should it be? A, his HIV risk factor. B, the most recent CD4 cell count and when it was done. C, the individual components of his single pill antiretroviral therapy regimen. Or D, whether he refills his prescriptions for ART regularly. You can go ahead and vote. And I will also say that to whoever's handling the technical part of this, that I'm no longer seeing the other part of the I'm not seeing the timer, but maybe it'll show up. I'll see it momentarily. Okay. So you're voting on this one. This is a good thing to know. This is sort of one of those, all of these things would be good to know. But the one that really matters when you're sort of evaluating a patient in 2024 with HIV. Well, why don't I go ahead and give the answer? And that's this one right here. And the reason being is I want you to kind of remember this, is that the people with HIV are divided into those who are taking their medicines and those who are not taking their medicines. And the ones who are taking their medicines are a lot like your patients without HIV. They're generally have virologic suppression. Their CD4 cell counts are normal or near normal. They just don't get opportunistic infections anymore. Now, you might argue that, the CD4 cell count would give you the same information, but, CD4 cell counts vary a lot. And if you told me that the person had a CD4 cell count 6 months ago of 300, but then also that they weren't refilling their prescriptions for ART regularly, I'd worry very much still about opportunistic infections. And then the components of his single pill ART regimen, obviously that's important to know what he's taking and why. But the initial evaluation, is this person adherent to ART? That's the key question. So let's go on with this case. The pharmacy confirms he regularly refills his ART. By the way, you can call pharmacies and almost always get this information very easily. And they tell you, furthermore, he's receiving Simtuza, it's a brand name, a single pill of darunavir, cobicistat, tenofovir, alafenamide, and emtricitabine. So you're treating him for community-acquired pneumonia with ceftriaxone and azithromycin. And he's also treated for a COPD exacerbation with inhalers and prednisone. And his outpatient records show that his viral load was undetectable on last several measurements. His CD4 cell count was normal when last checked 3 years ago. Interestingly, we don't check CD4 cell counts anymore in stable patients because they don't really tell us anything, provided the patient is stable on ART and virologically suppressed. We do check in people who actually are not on ART. So you order the Simtuza, and the hospital pharmacy tells you they don't have it. He has no one at home who can bring it in for him. And what do you do now? Your options are A, hold antiretroviral therapy during the hospitalization. B, order the individual components separately, even if they're not all available. C, order the individual components separately, but only if all are available. I put this up here because this is very much a real world phenomenon. There are so many HIV medications out there that hospital pharmacies do not stock them all. And this is an example of one that's not stocked in many hospitals. It's a single pill regimen. I already mentioned it has 4 different drugs in it. And the answer here is order the individual components separately, but only if all of them are available. And the reason being is you do not want to be ordering or administering partial regimens. These combination regimens are suppressive in combination. They're not suppressive when they're given as partial regimens. So that would be doable in most hospitals, that you would have all 4 of these available to you. The other thing you can do, obviously, is if someone does have someone who's available to bring the medications in, that would also suffice. So I put this slide up here because it is tricky. There are all these medicines, I put this one right here. There's his Simtuza, and this guy, David Serrata, developed this figure, and it's being updated periodically by some of the doctors and pharmacists he works with. And this is darunavir, cobicistat, and tenofovir, alafenamide, and emtricitabine, but there's no way you're ever going to remember all of these. So let me just tell you that the best regimens today are all integrase inhibitor-based regimens. The most commonly prescribed by far is the one that has bictegravir plus tenofovir, alafenamide, and emtricitabine, and that brand name of that one is Biktarvy. And then there are 2 others I want to mention because they're 2 drug regimens. One is dolutegravir lamivudine, that's comes as a single pill, Dovato, and then injectable cabotegravir or pivirine, which if people are on this injectable, it's every 2 months. Someone may be hospitalized during the time that they're supposed to get their dose. And then I wanted to also emphasize that patients with long HIV treatment histories are on different regimens from these sometimes due to intolerance or due to drug resistance. A quick digression for a pet peeve. This term, highly active antiretroviral therapy, is very outdated and it needs to be permanently retired. We prefer to say antiretroviral therapy. We've actually had effective HIV treatment since 1996. So it's been so long and everyone is on it. So basically don't Don't use this term heart unless you want to annoy your local infectious disease doctor. Okay, so how do you tell in your patient who's admitted whether their regimen is effective? Your options are HIV viral load, CD4 cell count, or both. As I mentioned previously, the people who take their antiretroviral therapy are virologically suppressed. So the answer here is HIV viral load. That is the key test to order to see whether the regimen is working. And I got involved in a clinical trial of bictegravir FTC TAF many, many years ago. And the results are really quite astounding. I entitled this slide, Current ART, look at that misspelling, apologies. Current ART works if you take it. And these are 5 years of follow-up in people on ART with this regimen. And you can see the results are kind of like the hepatitis C cure studies. It's just basically anyone who's taking this is going to succeed. You might see there's some drop-off here, but these are people who dropped out of the study. And nobody failed with resistance and drug-related adverse events leading to treatment discontinuation were less than 1%, less than 1%. That's pretty amazing. So if patients with HIV are all unsuccessful therapy, what then do they get hospitalized with? Well, it could be a case like this where it's a smoker who gets hospitalized with pneumonia, but I want to underscore this particular piece of epidemiologic data. The leading cause of death for people with HIV in care is now cancer, non-AIDS cancers. So that's that blue color right here. This one right here, that's the one that we see in clinical practice more than anything else. And second is cardiovascular disease. And so, I think there's something about the immune surveillance that is impaired in people with HIV, especially if they have years before they went on effective treatment, that even though you get rid of their risk for opportunistic infections by putting them on ART, they still have an excess risk of cancers. And these are diverse cancers. And if you combine non-AIDS cancers with HIV-related cancers, it's actually the most common cause of death for our patients in 2024. So be very vigilant to cancer as a diagnosis in people who are hospitalized with HIV for unexplained reason. So let's go back to our case. We're working through this case. The HIV viral load and CD4 cell count are both ordered. The viral load is less than 30. This assay goes down to 30. Hooray. The CD4 cell count, though, is 180, which is 24% CD4. And so the question is, should this patient be started on prophylaxis for pneumocystis pneumonia? And so he's admitted he's got pneumonia, got a suppressed viral load, but his CD4 cell count is less than 180. Should he get pneumocystis prophylaxis? Well, the answer for someone who's virologically suppressed and a CD4 of 180 is no. And I want to just stress this. The OI prophylaxis used to be a sort of cornerstone of HIV management, but these days is really much less important than antiretroviral therapy, and it's never urgent. If you have someone not on treatment and their CD4 cell count is under 200, then go ahead and start it. The most effective regimen by far is trimsulfa once daily. Dapsone and atovaquone are alternatives. Atovaquone, if you've never seen it, it's really quite the formulation. It comes in this yellow suspension that, frankly, is pretty disgusting. And we already know from clinical studies that if the viral load's undetectable for more than 3 months and the CD4 rises to even greater than 100, they don't need to be on pneumocystis prophylaxis. And we don't give anybody prophylaxis for Mycobacterium avium complex. So you thought I was going to let you off the hook for this case. Remember, a man admitted, smoker with pneumonia, treated for COPD exacerbation. So he's getting better. He's on antibiotics, steroids, and inhalers. He gets severe insomnia from the prednisone, and so he's treated with lorazepam, and he's ready for discharge on hospital day 3. And his discharge medications are fluticasone, salmeterol, cefpodoxime, and lorazepam. And those are his medicines that he's going to go out on. And I ask you, what potentially serious drug interaction with his HIV treatment was overlooked in his discharge plan? We've got azithromycin, fluticasone, lorazepam, and salmeterol. And I cleverly alphabetize those four for you as you think about it. And the answer to this question is actually inhaled fluticasone. Much to our surprise and everyone's surprise, it turns out that the pharmacokinetic booster that's part of his regimen, something called cobicistat, can cause iatrogenic Cushing syndrome with people who get inhaled corticosteroids. So many cases of these reported back in the early ART days. I've seen this numerous times, and it really can make you worried. And one reason why we use those integrase inhibitors that I mentioned is that they don't have as many drug interactions. But I can tell you that ritonavir and cobicistat, if you have a patient with HIV on either of these two drugs, and this patient was on cobicistat, they are getting a drug that blocks or slows metabolism through the cytochrome P450 system. And this can lead to an awful lot of drug interactions, some of them clinically quite devastating, including this one. Inhaled corticosteroids or injectable corticosteroids, you have this incredibly long elimination half-life, and it leads to iatrogenic Cushing syndrome and sometimes really devastating problems. So be careful with that. That's important. So many years ago, and then I'll wrap up, HIV lectures were about opportunistic infections. So the question is, do they still happen? And by the way, this was my figure from many years ago. I've used what it was like to manage HIV in the pre-ART era. So people get admitted with OIs? Yeah, they do. They do. And who are they? They are people who are not on antiretroviral therapy because they don't know they have HIV. They haven't been diagnosed yet. They can't take ART. They have severe side effects, so they can't afford it, or they lose coverage, or they won't take it because they're traveling down the longest river in Africa, also known as denial, and they're just basically not going to take it, or they have psychiatric illness, or they have addictions. So those are the people who get opportunistic infections. There is another group who have been on HIV therapy for a relatively short period of time. They start treatment with a low CD4 cell count. Their CD4 cell count rises, and then they get something called immune reconstitution inflammatory syndrome, or IRIS. And I want to remind people that CD4 cell counts for people who are not on ART are an excellent risk stratifier for opportunistic infections. This is the last of the great studies done on risks of OIs before we had effective ART. It was done from a Hopkins cohort. And you notice that almost all of the opportunistic infections happen with a CD4 cell count less than 100, not just less than 100. If you look at the median, it's even less than 50. So severe immunodeficiency is really required for these OIs to develop. So there's the take-home point there. And let's do our last case. This is a 42-year-old woman with weight loss, 3 months of gradual weight loss, anorexia and fatigue, outpatient workup for pancytopenia unrevealing, including a bone marrow biopsy, no longer able to work. Exam, she's got low-grade fever, a low oxygen saturation, 15-pound weight loss, thrush, her white count is low, her chemistries are normal, but her LDH is 340, her HIV antibody screen is positive, and her CT and chest x-ray look like this. This is a classic case of what pneumocystis pneumonia looks like. So what should you do now? Begin empiric trimsulfa, begin empiric trimsulfa and prednisone, await the results of an induced sputum for pneumocystis before starting treatment. Those are your choices. Well, as I alluded to, this is highly suggestive of pneumocystis, and you would begin both of them. And then when you're working the patient up, these are the really high-value tests to order. When not on ART, tests for patients not on ART, CD4 cell count and viral load. And then some of the other ones you'll see, your ID consultant will actually come by and recommend these tests. So when do you get an ID consult on a case like this? On admission or the next day, when ready to consider antiretroviral therapy, only if treatment has complication, or never? Well, I would make the argument that, person with an HIV-related opportunistic infection should get an ID consult relatively soon. So give us a call. We will not in any way say that doesn't sound appropriate. These are very complicated cases. And our case had a situation like this. She was started on empiric trim sulfa and prednisone. Her CD4 was 20. Her viral load was 140,000. She had pneumocystis pneumonia confirmed. Some people abbreviated PJP. That's fine too. Beta-glucan was greater than 500. That's a nonspecific fungal marker, and her induced sputum has a PCR that's positive for pneumocystis jirovecii. And we did start her on ART during the hospitalization and discharged on day 5. And I bolded the last bullet. People treated for pneumocystis pneumonia have a very high rate of complications during their 3-week course. So please discharge with close follow-up. We invariably see them a week after discharge, sometimes check in with them before then. Hyperkalemia, hepatitis, drug fever, all kinds of problems happen. I want to say that this is a clinical study. I'll just focus on just saying that most patients with advanced HIV disease should start treatment while they're in the hospital. And that is something that we typically do these days. Let's talk about IRIS. IRIS is this very interesting phenomenon where people get this exaggerated immune response. This is a person with massive subclavicular and cervical adenopathy from disseminated Mycobacterium avium complex after starting ART. And it happens, and people sometimes get a fever with it. But it's so much better than not treating the HIV that this is never a reason to delay antiretroviral therapy, never, except for one case, and that's cryptococcal meningitis. Cryptococcal meningitis is the only OI that's clearly documented that starting ART early leads to more adverse complications than starting it after 2 to 4 weeks of treatment of the cryptococcal meningitis. All the rest of them, we want to get people on ART as soon as possible. Not urgent, not like emergency, but during the hospitalization. So why call us? I'll give you the reasons, summarize here. Confusing test results on HIV diagnosis, a new diagnosis, suspected OIs, advanced HIV disease, detectable viral load, but supposedly on ART, usually they're not, concern for ART-related toxicity or drug interactions when considering that they should change ART or the patient's non-standard or outdated regimens or after a patient or healthcare provider has possible exposure to HIV. So let's go over our take-home points. HIV testing is accurate, but know its limitations. Always consider acute HIV for febrile syndromes in at-risk populations. Admitted patients order an HIV viral load, should be suppressed, continue that full ART regimen, watch for drug interactions, and expect the same medical diagnosis as non-HIV patients. For patients not on ART, it's different. There you get the viral load and the CD4 and plan to start ART during the hospitalization and discharge with close follow-up. So why don't I stop sharing and we have time for some questions, I think. Yes? No?
Yes, we do. We can sneak a couple in here.
Thank you.
So thank you, as always, for that. You got the some of our participants' minds moving, though. A few questions around jurisdictions where we have to ask for permission to test for HIV and the language that you use, because I know we have to here to kind of destigmatize that.
Yeah, I basically say we test everyone for HIV. Is it okay if I send the test? That to me is pretty accurate. One problem is the difficulty of getting a response in someone who can't give consent because their either mental status changes or they're critically ill. And in some states, you don't need verbal consent. In Massachusetts, you do. What I would suggest you do is do what you think is best for the patient. It's so much better for the patient to know their HIV status than not to know medically. That I'm not aware of a single case in the recent era where we have effective treatment where someone was tested in that context and they ended up having a problem, either medical, legally, or otherwise. The other issue that comes up sometimes is source patients of occupational exposures when they cannot give consent. And there, again, I think you argue the best thing for the health of the healthcare provider is for the source patient to be tested. So make the right decision for patient care purposes and don't stress over it too much.
Okay, thank you. A few questions about, you had mentioned if all components of the ART are not available. I think some people in the audience want to confirm then the best case scenario in that instance is to just hold it, right, while the patient's in the hospital and the medication's
Yes.
unavailable?
Exactly.
Okay.
What I would recommend, like, for example, in that case of the person taking a combination pill with 4 drugs, you're better off not actually giving any of it until everything is available. It shouldn't take too long. People can be off ART for 5 to 15 days without experiencing viral rebound. So it's okay. You have a little time to get the components. You may be able to get it by having someone bringing it in. You may be able to get it by having your pharmacy obtain the individual components. But don't give partial regimens.
Listen, thank you, Dr. Sachs, as always. An
You're
excellent
welcome.
talk. Thank you.
Thanks for inviting me.